Welcome, everybody. Welcome to Perfecting PT. We are very lucky to have with us today Strat Poulson. He is a doctor of chiropractic. Is it still doctor of chiropractic or is it chiropractic physician?
Chiropractic physician in some states, although in Texas where I am, that's not my title. I would be considered just a doctor of chiropractic.
Okay, great. So we're joined by Strat Poulson. He graduated from Parker University in 2021, immediately opened his practice, and currently owns his practice. I believe it's called Apex Chiropractic.
Correct.
Okay, and he also does international continuing education seminars for chiropractic. Is it primarily chiropractic manipulation?
Yes. So we're teaching what we would call adjusting, or what you guys would call spinal manipulations or joint manipulations.
Okay.
We teach that.
Okay, excellent. So we're going to be chatting all things chiropractic today, maybe a little compare and contrast with PT, but we would really like everyone to know today, like, what is the big difference between a PT and a chiropractor, how they really, in many ways, are both there to support you. For anyone listening, you probably know PTs who have strong opinions about chiropractors. You have chiropractors who have strong opinions about PTs or other healthcare providers. Like, the fact of the matter is, there are many chiropractors who are giving tremendous benefit to the community, along with other healthcare professions. So we're going to talk all things chiropractic, and we're very lucky to have Strat with us today. Is there anything else you'd like to add before we get chatting?
No, I say let's just get right into it. I'm happy to be here.
So the first thing, we were chatting right before we recorded, actually, and I want to know your thoughts, because I know from kind of my side of the aisle, there's a lot of PTs that are like, oh, why are you going to chiropractic when you could just become a PT? And I'd be curious to know if the same thing is being said on the other side of the aisle. Like what do chiropractors say about other, massage therapists, PTs, and not necessarily in a bad way? Because I think in many ways, sometimes like chiropractors inappropriately get a bad rap when so many of them are doing good work.
Yeah. I think generally in the profession, there's obviously like a little bit of professional pride. So you're like, go
Sure.
team Chiro or, go team PT. But I think generally, like when people ask me this question, and I've seen it a lot, like on the chiropractic Reddit boards or talking with other of my colleagues, the general kind of Chiro versus PT really comes down to, in our opinion, scope and freedom. So
Sure.
Because of, and I'm not sure how familiar your listeners are, there was a clash between the Chiropractic Association and the American Medical Association. This was, I believe, in the early 1900s. And it was basically the medical association saying that we were practicing medicine without a license, and we had to go to court, and basically we beat them in an antitrust suit. Basically, number one, saying that chiropractic is separate and distinct philosophically from medicine, and therefore we're not practicing medicine.
Sure.
But part of that case, we won an antitrust suit because there was an internal memo in the American Medical Association where they basically said they wanted to contain and eliminate, those are the words, contain and eliminate the practice of chiropractic. And so what's interesting about that for us in modern day is that creates this divergence where chiropractic cannot be kind of over-regulated or oppressed, if you want to even call it oppressed, by medicine. Where some of the other professions are still a little bit under the medical umbrella and have to play by their rules. Chiropractic, because of that case, really freed itself from that. And so you see a lot of things that chiropractors have, like we don't need referrals. We can treat, immediately and for however long we want in every state. We can order imaging like MRIs, CTs, even things like nerve velocity conduction studies and things like that without any referral. And there's a lot of different kind of aspects of our scope and things like we can take blood work in many states. We can order blood work in all states, analyze those, assess those. So for us, a lot of times when you're looking at, like, let's say PT, you might say, well, for PT, you seem to have a lot better, especially than we do, entry-level jobs and abilities to go work for someone else. You can go work for a hospital anywhere in the nation. You can go work for a private clinic or an outpatient clinic, pretty much anywhere in the nation, get a nice, stable job, usually decent benefits and usually decent pay. Now, you guys might argue you'd like better pay, but, compared to what we pay our associates and our new grads, you'd probably be pretty happy with your pay.
Sure.
So in chiropractic, the profession is much less integrated into hospitals. The only hospital systems that really consistently have chiropractic care are the VA hospital systems. And we don't have as much kind of insurance acceptance and reimbursement. And so because of that, When we graduate, you're really stuck with working for another doc who's opened his own practice or opening your own practice.
Okay.
And so it's very highly rewarding for the entrepreneurial spirited chiropractors, but for the majority of people that just want to come out, have a nice stable job with benefits, it's actually not a very good profession, in my opinion, to provide you a stable salary and benefits. So to me, it really fundamentally, when we talk about chiro versus PT in our profession, we talk about, stability versus instability, like unlimited ceiling for owning your own practice, but no base, no safety net,
no floor,
and then freedom.
Cool. And so do you feel that the lack of, could I say regulation?
Oh yeah.
Yeah. Would you say that the lack of regulation or oversight from a larger medical board, do you think that leads to some of these kind of wild and out there chiros that give the other ones that are good, evidence-based, informed, smart chiros a bad rap?
Yes, I do think the lack of any type of central regulation. Now, we do have our own boards to answer for, and certain boards are more likely to penalize you for certain things than other boards. So things that fly in one state won't fly in another state, for example. But we're basically self-regulated from within our own profession. But that's allowed for a lot of diversity in thought, diversity in philosophy, and diversity in treatment. But one of the downsides is that what I'm recommending, just if I was to recommend a random chiropractor to a patient who's in another city, I'm not super confident that they're going to walk in and get a treatment that looks like a treatment that they would get at my office. And so it can be very difficult to make recommendations. It can be very difficult to predict what kind of office someone's going to come into. And then that leaves a lot of room for, what people could argue might be substandard care, or for, more out there kind of energy healing. And there's a lot of kind of different things that can kind of exist under that chiropractic banner that maybe, many chiropractors would not be thrilled about, but we kind of can't do anything about, because the same freedom that has given us our ability to self-regulate is now kind of also one of our issues, is that chiropractic can mean 100 different things to 100 different doctors.
Right. No, in many ways, it's almost like free speech. Like, if you're allowed to say whatever you want, and, you are going to also have to have a decent amount of people who are saying random crap or stuff that is not beneficial amongst the many positive aspects of the profession.
Yeah. Sure. And enforcement's going to be different. I mean, obviously, the one thing you'll certainly be enforced on is any type of patient abuse, certainly financial abuse, or breaches of patient information, breaches of patient confidentiality, stuff like that are all pretty highly enforced upon within our own regulations. But some of the more out there philosophies and things like that, we kind of just have a live and let live stance on it. So people might be saying outlandish things, and it's rarely enforced upon.
Sure. And so when you say that so is there not a national governing body for chiropractic? It's pretty much state by state?
Yes. So we have a national licensing board, which all chiropractors have to pass all 5 parts of the national boards in order to earn their license, no matter what state you're in. However, all of your individual regulations come down to your state. And so that means that you have to be licensed to practice in any state that you practice in. So there's no easy way for me to hop across the border from Texas to Oklahoma and start treating patients. I need an Oklahoma license to do that, or some type of temporary approval. So all the regulation comes from your state chiropractic board. We have no national. We have national organizations, but that's more of a membership organization. So you're I kind of identify with your rules, agree to kind of follow your rules, but they have no enforcement mechanism besides kicking you out of the group.
Oh, right. Okay. Yeah. So it's like we have the APTA, which essentially, and what's it called?
The ACA, the American Chiropractic Association.
Okay. Got it. But there are other national boards that you say that you can be a part of.
Not that will grant you a license. You must pass what we call the national board exams. There's 5 of them.
Five.
Any chiropractor in the nation has to pass all of those, but they can only be licensed and therefore, penalized or regulated in their own state.
Okay, got it. So, I'd love to know a little bit more about how you guys are educated. I think that's a big one, because I think everyone assumes PT is like, oh, I go to PT and I do some exercise, or I go to PT and they do some massage or they stretch me. And obviously there's more to PT school than that as well. But I think a lot of people think chiropractic, they're like, oh, they do adjustments. And I think I'm starting to see now, like a lot of chiropractors are going more into the space that they were originally in, which chiropractors were the original exercise specialists, in my opinion.
Mm-hmm.
Like they were doing exercise with manipulation long before physical therapists started bringing in exercise with manipulation. So I'd love to know just a little bit more about your schooling. Like, is chiropractic, is it 4 years? Is it 3? Does it vary? What are kind of the general topics you go over in chiropractic school? Because I think a lot of people that I've talked to that are going to listen to the podcast are students, including undergrad students that are trying to decide if PT is for them or if they want to be a trainer or a chiropractic. And we try to, or there's people who are in a profession who may prefer to switch professions. And so I just want to give people a pretty clear overview of what that generally entails.
Yeah. So you're going to need your standard 4-year science-based undergraduate degree. Then you go to the graduate program, which is the chiropractic schools, chiropractic colleges. There, it's typically between 3.5 years to 4 years that you're in school. And then we do our kind of internships, or what you might consider like a residency, basically during our schooling process. So we don't have a postgraduate residency unless you elect to go and seek one out.
Okay.
And you just hit the road ready to go. So your schooling, I mean, your first couple, like I'd say 1.5 years, maybe 2 years, is going to be pretty heavy. You're taking anatomy, physiology, you're doing gross anatomy, your cadaver dissections and things like that. You're taking pathology, microbiology, what else? Biochemistry. You're kind of covering all your science basics, physiology, so that you understand what's going on with the body. Sure. And then you start to get into more of your clinical courses. We have a pretty heavy emphasis on imaging analysis.
Okay.
So we had 3, maybe even 4 separate courses that were all on X-ray analysis. We had a much shorter, more truncated MRI course. And then during the clinical phases, you're taking clinical neuroscience. So you're learning dermatome testing and reflex testing. And then you have your clinical orthopedics. So all of your Kemp's test or your, prone knee bend or your straight leg raise, that type of stuff. You have a few courses at the end. They kind of have these courses that are kind of like putting it together. So they'll watch you perform like a neurological evaluation and then watch you do your orthos. And then you kind of create a mock diagnosis based on what you're finding. And they confirm, or they kind of, it's a clinical thinking, diagnosis and management type courses towards the end of the program. And then you enter into your clinical internship. And also, obviously, very close to the beginning, I don't think you do any adjusting in year 1, maybe at the end of year 1. But then you get into your adjusting courses. Your adjusting courses follow you all the way through.
Okay.
We have one course. And we have 3, where I went to school, we had 3 terms per year. So 15-week terms, 3 of them per year. Yeah. So we have one term on like physical therapy, what we would call physiotherapy modalities. So this is like electrostim, hydrocollator packs, like heat, ice, taping, stuff like that. Sure. And then we have one term on our active rehab. And this would be like movement assessments and what they would call interventions, which would be just, maybe it's going to be a kettlebell goblet squat, or maybe it's going to be sit to stand practice, things like that. We don't have any like post-stroke rehab or post-surgical rehab or anything like that. It's one of the reasons why you really don't see chiros in hospital is we're not trained, and that's not really an area where out of the box from university, we're ready to step in and fill that role. We have no training in like gait retraining or things like that. But it's basically a general movement assessment and rehab type of application. So non-surgical, just post-injury rehab, or even wellness, what we consider wellness rehab, calm it down, get it strong. And then we have our clinical internship where you basically put all that together. And that's where a lot of students begin to create their treatment approach. What's interesting about chiropractic is it's almost always considered appropriate via your instructors or the people overseeing you for your treatment plan to just consist of manipulations.
Okay.
However, additionally, they do like to have you doing soft tissue or modalities or rehab, active care, and bringing all those things together.
Okay.
And that's changing a little bit in the schools now. We're getting a much heavier emphasis on rehab and active care in chiropractic over the last 10 years or so, I'd say.
Sure.
But even with that increased emphasis, you're not really going to get anyone batting an eye if your treatment plan is, I'm going to adjust them this many times, and that's the treatment plan.
Sure.
So we do have that heavy emphasis on joint manipulations and things like that.
And so so the manipulations that they focus on in school, like I think people think chiropractic and they think spine, like spine and pelvis. Like how much of your manipulation training is done with extremities, or is that done after school?
So I would say for most schools, it's very little. We have one course, which is called extra spinal adjusting techniques. So that would be your extremity adjusting techniques. And again, it's one term. So we're getting, our entire schooling is filled with spinal adjusting techniques. And then we get one term on the extremities. Sure. And oftentimes what I hear from people when I teach the extremities, because I do them differently, I learned them at outside seminars, separate from my main curriculum. And often what I hear is just like the techniques that we learn in school are not sufficient. They're not comfortable. They're not appropriate in some cases. And so a lot of chiropractors will eventually abandon extremity joint manipulations because they're more comfortable and have the majority of their training in spinal joint manipulations.
Sure.
And then what I would also say is that the traditional chiropractic philosophy also places a significant more emphasis on the spine for philosophical reasons as opposed to physiologic reasons. And so a lot of chiropractors will also view the extremities as not important. So you may have some docs who are more committed to like the core old school chiropractic philosophy that refuse to adjust the extremities because they view them as non-important.
Okay. So, and I would love to know more about that. I have started to learn more about kind of philosophies and systems from my current boss, who's a mentor of mine, who's one of the original postdoctoral fellows in orthopedic manual therapy in the United States. And so he's always telling me like, oh, well, this person gave us these theories of intervention and this person gave us that. And I'd like to know more about the philosophies, if you're comfortable with that. Like, what is the kind of OG chiropractic philosophy about the spine? Like, is it that if the spine is adjusted correctly, like everything will flow out from that and everything will self-correct? Or, I mean, yeah, I'd love to hear your thoughts.
Essentially, yes. And, I may not be the most scholarly person to talk about philosophy, but I'll give you my professional understanding and from being in the profession and going to school. So
yeah, and I'd love that.
So we had some original kind of founding concepts in chiropractic. One of them is innate intelligence. You could kind of view this as like your life force or that which sustains the body that is separate. Some people can kind of equate that with a soul, but in chiropractic it's different and kind of distinctly non-religious is the way that we're taught. So you have this, you could say, a homeostatic mechanism or a life force that sustains the body. And that is believed to be derived from a universal life force that sustains the universe. So, rocks stay as rocks because universal intelligence makes them that way. Humans stay as humans in a functioning organism because innate intelligence makes you stay that way.
Okay.
So the founding idea is that misalignments in the spine, which we, I believe, co-opted the term subluxation and then have refused to get rid of it. But basically, a misalignment in the spine, which we would call a chiropractic subluxation, reduces the flow of innate intelligence. That's been conceived as like, the brain is no longer able to communicate with the tissue cell effectively, or we have this breakdown in the flow of the sustaining life force.
Okay, and that life force comes from the brain, or does it come from outside?
It comes from the universe to the individual, then flows down essentially from the brain and out to the tissue cells is how this is kind of managed.
Okay, got it.
And so the subluxation is a disruption in that process. Correcting the subluxation through the chiropractic adjustment is what restores proper flow of innate intelligence, which essentially just rights the homeostatic mechanism.
Okay.
So that is the kind of, and I'm sure if you had a very philosophically driven chiro on, they would have tons of issues with the way that I've just explained that. But at a fundamental level, that is kind of how it works. And we love just within our own profession to argue about all of the specifics of these. There's like 206 different definitions of subluxation. Sure. So it's really quite a mess internally.
Okay.
But that's essentially what it was from. And so, we're talking about late 1800s, early 1900s. So we're in the same time period as like bloodletting, seances, leeches, all this kind of stuff. And so that was their understanding, that they were correcting small misalignments. That was the cracking sound was a bone racking back into place.
Sure.
And almost like a garden hose, like if you step on it, you have reduced flow. That was how they envisioned innate intelligence. And when you take your foot off the garden hose by doing the adjustment, flow is restored and proper health is restored.
Okay, cool. So if that's kind of the OG system that people we'll say indoctrinated with, kind of what is your approach? Like, what is your general approach to chiropractic? Like, and it could be from a person, if you have specific, like, kind of godfathers of chiropractic that you kind of align with, or at least ideas, like how do you view chiropractic?
Yeah. So I view chiropractic through kind of like a hodgepodge of biomechanism, neurophysiology, and a more maybe modern pain science approach through like sensitivity and input and feedback.
Okay.
So when I approach the body, I'm basically saying is there anything in here that is not functioning properly in terms of the joint physiology, the mechanics of the joint? Is there anything that is hypersensitive when it maybe shouldn't? So you're have increased pressure pain thresholds, a movement that would normally be not non-painful is now painful. And so I'm looking at that as a whole, and I'm saying, where can I access either like the physical body to create a neurological output that's going to reduce sensitivity, reduce pain, hopefully reduce, fear avoidant behavior and things like that. But we're basically using the adjustment to create afferent barrage to get this kind of resetting of motor output and pain processing is how I view chiropractic.
Sure. And
so you can have something that is it's just physically stuck, that joint's not moving properly, whether that's from osteoarthritis or whatever, right? And then you can have joints that have no what would say, anatomical deficit or dysfunction, but have some type of physiologic dysfunction. And so that's really where I view the chiropractic adjustment is coming in, as we're altering all of those sensory processing pathways. We're altering the way the patient perceives themselves and helping them move better. And my goal, because I only adjust, so I will refer people out for rehab or for soft tissue work and those other things. I just focus on manipulations. But that's my general approach, is that by getting them moving better and feeling better, they'll go back to their normal activities, in the hopes that going back to the normal activities is enough to help them live healthier and better lives.
Right. And I agree. Like, that lines up very much with kind of how I view the body. It is essentially a feedback mechanism. You provide a stimulus, whether that's through manipulation, or in PT, we also do like graded mobilizations or other soft tissue exercise interventions. And to your point, like, the hope is we put in something and the resultant neurological changes result in better movement, decreased pain, better joint mobility. And again, if they return back to normal, the hope is if they do that and their body has this period where they're not in as much pain, it will just kind of normalize the system and they'll be able to go back about their business until they need one of us again.
Yes. And I think that's the argument that supports, for example, like wellness or maintenance care, right?
Yeah.
Some people may not need significant rehab. Like just going back to work might be enough of a physical stimulus that kind of constitutes its own rehab. So just getting them back to normal activity gets rid of their problems. Like, their problems aren't severe enough that they need a longer period, more structured rehab to get into what they're doing. And then some patients do need that. And that's where I'm typically referring to the PT. And at my office, it's my office, and then the room next door is a massage therapist, and then the room next door is a gym floor with a room attached, and a PT works in there. We all work on our own, under our own banners, but we cross refer. So it's very easy for me to be like, you know what? I think at this point you need to go see Sheldon, our PT, and just walk them right over. Hey, Sheldon, this is, Mary. Mary's needing a little bit more than I can do for her. So I'm going to get her cracked up and send her to you, and then hopefully you can help, do the rehab plan. Sure.
And I honestly, I think that's a good model. What was I going to ask? Yeah. I'm curious. So you had brought up manipulation. Do chiropractors generally teach graded mobilization, or is it always what like DOs call it like an HVLA, like high velocity, low amplitude? You guys call it an adjustment. We call it a manipulation. Whereas if I'm not taking it through that end range, it's called a like graded mobilization. Does chiropractic really go into any graded mobilization, or is it primarily manipulation?
We do go into those like grade 1, 2, 3, 4, or whatever.
Yeah.
However, I would say that it's certainly not one of our emphases or something that we focus on a lot. We focus on high velocity, low amplitude thrusts. We call them the adjustments, but we refer to them as HVLA.
Okay, got it.
Manips. And so we do have some different techniques in chiropractic that we would consider like low force technique. They use positional releases and things like that. There's like torque release technique, activator technique. There's a few different kind of techniques that are focused on low force. Although typically what you're going to see out of a chiropractor is that they're utilizing that for one of two reasons. They're utilizing that for what they would consider a higher risk patient. So someone who's elderly or osteoporotic, someone who's very young, like an infant, or somebody who's had a negative experience with high grade manipulation before. They don't want that. Or sometimes as docs get older, or even younger docs, they want to save their body. And so they're not creating those forceful movements. They'll switch to these low force techniques and treat primarily that way for all patients, regardless of the patient demographic. So, but I would say with chiropractic, there's a very heavy emphasis placed on HVLA manipulation. And so the majority of chiropractors, the majority of treatments, and I certainly myself, very rarely use below a grade 5, like full blown HVLA manip. It's just not part of the approach. One of the reasons is we really focus on, there's this, I wish I could get, I'm not the most sciencey person. I love to nerd out on research papers and stuff, but there's some studies that have been done about certain neurological receptors and their firing thresholds. And so a lot of what we're doing is trying to get the maximal afferent barrage. And you get that when your thrust speed or your impulse speed is sub 200 milliseconds. Is what this study has shown. And we really take that to heart. So even if we're setting up a manipulation and the cavitation occurs during the setup, we will not abandon the manipulation and view that cavitation as a sign of success of the manipulation. We'll still deliver the impulse. Because not just the physical cavitation of the joint is important to us, it's also the speed of that impulse triggering those receptors and giving us a large afferent barrage. So a lot of what we want is coming from that barrage. And so to us, the emphasis is placed on that higher intensity thrust to make that happen.
Yeah, and that makes sense. So I think I understand. No, bless you. I think I understand what you mean by afferent barrage is, again, you're creating a large stimulus to try to get the body to create these cascades of effect. Could you tell me a little bit more about what maybe, because I guess I would just like to know more about the afferent barrage. Like, is it, because I know like with dry needling, when I did courses on that, they're like, oh, substance P and these different things are released. Is there anything in particular that you're really trying to get in there, or is it just high like afferent stimulus into the system so that it resets?
Yeah, I don't know how much I could get into the neurology of this because, again, I have one neurology course. We have chiropractors who are great at this. But, the argument would be, okay, well, I could hit you with a shovel.
Yeah.
That's going to create a large degree of afferent stimulus. So why don't I hit you with a shovel instead of adjusting you, right? So there are different pathways that are activated. One of the big ones is descending inhibitory control. So one of the signs we look for around an area we might want to adjust is local muscle spasm. So whether that's the erector spinae musculature or whatever, you have an abnormal high or asymmetric tone in the musculature around the area. Usually you're combining that with an abnormal sensitivity to pressure. And then we adjust that. We're looking for that afferent barrage to essentially from the spinal cord come back and stop that muscle spasm. I believe that's through a combination of the spindle cells and the Golgi tendon organ. But then you also have these higher pain control centers and pain processing centers in the brain. And we know that changes occur in, whether they're temporary or long-lived is kind of up for debate right now, but you have these changes in pain processing up in the brain, which can then basically activate descending inhibitory control and turn the sensitivity of those peripheral tissues down. And so there's a lot of neurophysiological changes that are occurring that someone more versed in it could definitely tell you.
Oh, sure.
And that's essentially what we're trying to take advantage of.
Excellent. Yeah. And for anyone listening who happens to know this stuff, don't give us a hard time. We're just, we're just
doing
trying
our
to,
best.
we're just trying to do our best here. So I'd love to know more about kind of your process for manipulation, because I think that may be a big difference between PT and chiropractic is when we look to manipulate someone, there are kind of some signs that would say we don't touch them in certain ways, period. It's like there are kind of yellow and red flags that would say, I don't perform this manipulation. And I know you had brought up, like, you're like, generally speaking, a manipulation is warranted and appropriate. And so I'd like to know kind of how you go about managing that, especially if they're all grade 5. I would just be interested to know more about that.
Yeah. So, and perhaps I misspoke. I think what I was trying to say is that
Sure, that happens.
no one would bat an eye at you if your treatment plan was consisting only of manipulation. Right.
Got it. Okay.
Now you still have to make the distinction of, am I going to treat or not treat this individual? Right. So there are patients that I turn away. Right. And we go through the same training and process of yellow flags and red flags. So, if there's any type of gross instability to the joint, we're not going to deliver a grade 5 manipulation to the joint. If there's a chance of fracture, chance of infection, chance of other pathologic disease process, we're going to refer out or fully evaluate that. But I am comfortable with, I think, a bit more risk, if you even want to call it risk, or a bit more complicated presentations than many chiropractors and certainly many PTs are. I have no issue adjusting the spine of someone who's had a surgical fusion. I have no problems adjusting the issues or even the level of a prior or current disc herniation.
Okay.
Of, for example, a lumbar spondylolisthesis, so like an L5 spondy. Mm-hmm. I will manipulate those segments. In the cases of fusions, they move just like any other segment, except the few segments move together. Now, part of that is, the amount of force that you're putting in is relatively small. Sure. If you're using an amount of force that could, fracture a screw or bend a rod or something like that, surgical hardware, you already have the first problem, which is you're using far too much force that you need to adjust a small little area. And so there's things like that. So, each doc is going to have their own risk kind of comfort level.
Kind of balance.
And I think for me, a lot of that changed because I saw a lot of complicated cases and just kind of ridiculous things at the VA when I was doing my internship.
Oh, I can only imagine.
So becoming more comfortable with treating people with all kinds of horrendous injuries, all kinds of hardware, all kinds of comorbidities, it allowed me to watch, for example, a mentor of mine adjust that patient and nothing bad happens. And then I start adjusting these patients and nothing bad happens. And the more you get comfortable with that, the more you realize, okay, at the fundamental level, we're just kind of putting a small controlled force into a little Z joint. And you start to consider to yourself, okay, what are the things that could go wrong? And just the possibility of things that can go wrong is not a very long list. And especially the more that you control your variables and the more that you control your technique, you can even minimize that even more. And so you're going to go through the whole process of ruling in, ruling out patients, whether they're going to receive manipulation or not. Some chiropractors will do more than manipulate. So maybe that patient's ineligible for manipulation in one region. They do soft tissue or rehab or therapies in that region, and then they adjust the other regions of the spine. It's going to look a little different for everyone. Because I only adjust, my main concern when a patient walks in is, number one, is it even appropriate to adjust you, or are you in the wrong place?
Sure.
If it is appropriate to adjust you, is it appropriate to adjust you everywhere or only in some regions? Okay. And then what is the safest, most reasonable, most applicable way to proceed? So I have a variety of techniques to adjust every region in the spine. Mm-hmm. Some of those techniques are better suited to certain body types, certain presentations than other techniques. So I go through this list of, are you even safe to work with? If so, everywhere in your spine or only some places? And then what's going to be the most appropriate techniques to select for those regions? And that's kind of how I go through that process while I'm going through the history and the exam with the patient.
Sure. And I the people I've talked to that are listening to the podcast, this is the part they like most. I'd love if we could chat more about that system. So how are you determining if someone is appropriate for chiropractic care? Because I think in some cases, patients come to me, maybe they are seeing me for any number of reasons. And they say, I haven't been to the chiropractor in a while. I've kind of been wondering if I should go. And, I don't always know whether or not they are appropriate for chiropractic care. And like I said before, I think there's a bias in PT where I'm like, hey, they thought about going to a chiropractor and someone's like, no, don't send them to the chiropractor, even though that could be a very beneficial kind of co-treatment to make this person's outcomes the best. So yeah, how do you know that they are appropriate for chiropractic care?
Yeah. So, I mean, a lot of that's going to come from your history and from your exam. And also like what conditions your patient is presenting with and how comfortable you are with them. I'm an upper body specialist. So I really focus on like neck conditions, cervical radiculopathies, disc herniations, things like that. Headaches, chronic migraines, and TMJD. So those are kind of what I focus on in my practice. So when people come in with stuff like that, I'm already like, cool. Now we just need to make sure that there's nothing more nefarious going on and that you're cleared to begin treatment. But you're going to go through your history. You're looking for your red flags, yellow flags. After you go through your history, you're trying to identify, does this sound like something that is, inflammation based? Does this sound like this is something that is mechanically based, neurologically based, sensitivity based? And to what degree can I be expected to be successful in affecting that with manipulation alone? Right. That's my question. So I can target if that's appropriate or if they need to go to PT. So, like I had someone come in the other week and they were having like essentially an Achilles tendinopathy. Mm-hmm. And what I said to them was like, I can adjust your ankle, I can adjust your knees, I can adjust your hips and your pelvis. That might change the way that your body's distributing force. I don't know if it's going to move the needle for you a ton. So if you would really like to be treated today, I will adjust that. We'll see how you do. But I would really like to send you over to Sheldon or to Andy, our massage therapist, and have them evaluate you, because there might be some load management or some grade of exposure that they can do with you that's going to get you more bang for your buck, right?
Sure.
With someone who comes in with chronic migraines, they're clenching and grinding their teeth at night, I often have those patients come in and they've been to the dentist. The dentist is kind of running out of options. They've done night guards and stuff, and now they're talking about surgery. They sent them to PT. It's just not really working for them. And so they end up in my office going, you're my last stop before I let someone cut open my jaw. Right.
Sure.
And so those patients, I always love that. The more specialists and scans and things a patient has had before they arrive to me, that the more confident I am. Because Absolutely. If everyone else has struck out, the odds that it's something that is in my wheelhouse where we can just adjust you and start to see big improvements, I think go up.
Sure.
It's like we've ruled out all the nasty, ugly stuff and everyone's kind of stumped. That's usually where chiropractic shines. And I think chiropractic is exceptionally good with neck pain and headaches in particular. Sure. We have some studies that show we outperform medications and outperform other therapies and things like that. But it also depends on the complexity of your cases. I run what I would consider just a general practice. So, there's nothing particularly special about my patient demographics. So I get a lot of like, hey, I slept weird last night. My neck is kind of bothering me. I'm having trouble turning my head. You might call that a facet syndrome or, whatever you want to call that.
Sure.
That type of presentation is very amenable to manipulation. And usually they resolve in 1 to 4 visits. Sometimes it's just immediate, and sometimes you got to go and hit it again once or twice before they're back to normal. And then, you get someone who's come in, they've had multiple car accidents, whiplash, they've got disc herniations, they've got, radicular symptoms going down the arm. That's going to be a more complicated case. It doesn't mean that manipulation is not appropriate. It just means that you might need to consider adding in other therapies, or the frequency or duration of your manipulative care might need to change, or even just the approach to your manipulative care. I think at this point I might have forgot the question. Have I answered your question?
Yeah, I'll back you up, because I think this happens with most of my guests. So you said first you're clearing out the nefarious things, and yes. I would really like to know, a big part of this show is just how does Strat do his thing? Like what does he do, and what that is most useful? So like, how are you clearing out those more nefarious things, and what are those more nefarious things you're looking for? And we can kind of walk through the different things you brought up, because you did answer the question broadly. And I'd like to know like what you as a person, you're like, because I think you are an expert. The things I've watched, I think you're very good. And I would like to just know more about your system. So people are like, oh, that guy's a smart guy. I'm going to start including that in some of what I do. So kind of run me through how you're, Daisy, hey, not right now. We have a St. Bernard, and she's a bit of an attention hog. Go away. So, yeah, like what are the big red, like nefarious things you're looking for, and how are you screening them in the subjective first? We'll go through the subjective portion.
Yeah. So obviously any type of traumatic injury, depending on the severity, like, they were in a fender bender, no airbag deployment, no hospitalization, whatever. Maybe we don't need to order x-rays, right? But if they've been in a significant trauma, we're looking for x-rays, we're looking for other things to make sure that we're not missing anything that's going to put them at further risk.
Do you guys use the Canadian C-spine rules as well?
It is one of the things that we use. I wouldn't say that every single member of the profession does, because there are many chiropractors that will take x-rays for every patient for no reason. I'm sorry, I shouldn't say for no reason. They will take x-rays of every patient because what they intend to do is look at the x-rays, analyze the alignment of the patient's spine, and they plan to deliver care in a manner to correct that alignment. Okay. I don't really believe in, a alignment of the spine. And so I'm not going to draw lines on x-rays, determine degrees, pick a single segment and try to target just that segment in the correct direction. For me, I'm just looking at the patient's general capabilities, the patient's general sensitivities, and I'm approaching the spine that way, primarily through physical exam and palpation and range of motion assessment and stuff like that.
Sure.
So, we are all taught the Canadian C-spine rules and things like that in school. We're all taught, judicious use of x-ray. But that is one of the big issues I would say that we still have in chiropractic is a lot of chiropractors are doing tons of x-rays. In the most egregious cases, you have docs who are taking an initial set of x-rays, treating, and then taking a follow-up set of x-rays to look at alignment after. The patient comes back in for their next treatment that same week, and they get before and after x-rays on every visit. So you might have a treatment plan that's like 72 visits over however many months, and the patient's going to get double the amount of visits of x-rays because they do pre and post. So those would be the most egregious examples. Now, that is probably a very low number of chiropractors because most docs will take an initial set of x-rays, treat for 2 or 3 months, and then take a follow-up set and see where they're at and reevaluate. Me personally, I take very few. I might order x-rays on a busy month 5 to 6 times, and on many months I order no x-rays at all, just because they don't meet any of the criteria that I would consider eligible. Based on those C-spine rules or the Canadian guidelines and just general things that I'm looking for. Because primarily it's like trauma or insidious pathology. If there has been no trauma and there is no insidious pathology likely from their presentation, and I don't suspect any problem with joint integrity through osteoarthritis or whatever, then I don't need a picture. I'm just going to see what's going on and we're going to get to work.
Sure. So, so you had brought up trauma. So like motor vehicle accidents, we know that's a big one associated with chiropractic. And you said there are insidious things. Like how do you personally, like what questions are you asking or looking for to see if there may be other things going on that would prevent them from receiving chiropractic care?
Yeah. So some of the big ones are like cancer, infection, basically, do you belong in a medical doctor's office instead of my office, right? Like, so do you have some type of infective disease process, some type of neoplastic disease process? Do you have some type of just organic disease process, like a cholesterol issue or a high blood pressure issue or things like that? So on your screening form, it's like, are you experiencing, unexplained weight gain or loss, nausea, vomiting, hair loss in libido, suicidal thoughts, are you having fever or chills at night? All of those constitutional, what we consider the review of systems, right? So they go through this whole checkbox. And obviously, as you're going through that, you have someone like, insomnia. It's like, well, sometimes I can't get to sleep as fast as I would like. Okay, so, all right, so you don't really have insomnia. You just, so patients sometimes don't understand quite what we're getting for. They'll say night sweats, and you ask them, it's like, oh yeah, sometimes my house is too hot and I sweat at night. It's like,
you're like, yeah, right. No duh.
Yeah. Okay, great. Moving on, right? But you got to go and talk about those. So you're looking for all those nasty things in the review of systems. And then, if there's anything in there that is not adequately explained by the patient not understanding the question that needs further review, I'm typically just going to send them straight to the GP. I mean, we have the ability to order blood work or to order your analysis or to do all this, but it's like, if I'm not going to treat, why would I do the analysis? So
absolutely, sure.
Send it to the doc, let them order the panels they want, let them, do whatever they want, and then treat you however they want. And, if you end up doing all that investigation, it's not related to your problem does end up being mechanical, then come on back to me. I'll be happy to get you in and we'll just pick up where we left off.
Sure.
But generally,
I just have a quick interruption. Does having high cholesterol, diabetes, high blood pressure, does any of that inherently preclude them from receiving care? No,
but there are considerations. So you might consider those, like, for example, yellow flags, right?
Okay.
It's going to change what you do. So, someone who has high blood pressure in a rehab setting, like maybe you don't want them doing a lot of prone exertion. So maybe push-ups would not be as good an exercise selection as like a seated machine, chest press or something like that.
Sure.
Because of the concern of the recumbent position affecting blood pressure. So same thing applies to chiropractic. High blood pressure is an increased risk factor for stroke. Diabetes is an independent increased risk factor for stroke. Chiropractic is kind of paranoid about stroke. And also we get blamed for it a lot. So we really try to make sure that all of those types of symptoms are things that we're dotting our I's and crossing our T's, because even if we've heard multiple stories from colleagues where patient shows up to their office showing clear signs of stroke. They call an ambulance. The ambulance takes the patient to the hospital. It's relayed somewhere in that process that the patient came from the chiropractor. And even though no manipulation was done,
and it's assumed the chiropractor caused it.
Yes. Or, let's say if there's a patient that I manipulated their neck last month and they happen to have a stroke today. They'll say, oh, well, you saw the chiropractor, you got your neck manipulated, so the chiropractor is the cause of your stroke, even if there's no temporal connection. Now, obviously, there can be a delay from the initial onset of an injury to the stroke, but typically a month is too temporally disassociated. Right. So, but anyways, that's something that we're particularly concerned about. So I'm always like, if someone comes in with neck pain, headache, especially migraine with aura, now we got to really get into it. Like, so, have you had visual changes? Yes. Have you had like double vision? No. Blurry vision? Yes. What do you mean by blurry vision? Is it like a spot that you can't see? Is that spot spreading? Is it accompanied by your scintillations and your typical aura symptoms? Is it accompanied by nausea and vomiting? Yes. Okay. I'm looking at them to see if they have any asymmetrical facial features of drooping. One eye is not symmetrical with the other. They're able to focus, when you're doing your fields of gaze and stuff like that. Have you had any sensory issues, any loss of consciousness, trouble speaking, trouble swallowing? You go through this whole, I don't know what they call it for you guys, like the 5 Ds and 3 Ns or whatever. And I don't know the acronym anymore. I just kind of have the parts of it memorized that I go through every time.
Yeah.
We're just confirming that. So no visual changes, no changes in hearing or balance, coordination, speech, blah, 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 loss of consciousness. And so then at the end of all that, you're like, okay, this is a typical migraine with aura, or perhaps it's a migraine without aura or whatever. You're classifying the headache, and then you begin treating. If it's not a headache, it's just neck pain. You also can then go in, and I'll frequently do this for patients who I've got them saying yes to a few of those, and it's making me feel uncomfy. Mm-hmm. You can do pre-manipulative positioning. So I'll take them and place them into an extension rotation. I start from seated. So all I do is I tilt them back and rotate them in not maximal range at all.
Sure.
So, they're 45 degrees of rotation and whatever degree of extension, just head tilt, and just wait.
Yeah, like a vertebral artery occlusion test.
Exactly. We're going to see, do any of those symptoms appear? No. And then maybe I'll put them in a manipulative position. So I place them down on the table and put them like I was about to adjust and apply just a little bit of overpressure. So not a thrust, but overpressure into the joint. And I just sit there and wait. And wait, do we have any onset of those symptoms? Does any change in position cause those symptoms? And so you run down the line. Now, pre-manipulative screening is not terribly reliable for stroke. And unfortunately, for all of us, there are not any really strongly research-supported screening tools for stroke. So you got to do the best that you can.
I'm not really sure I understand what you mean, meaning a stroke could be caused by manipulation?
No, for detecting a stroke in progress.
Oh, detecting a stroke in progress. Okay, got it.
So it's one of the most commonly misdiagnosed things, not just with chiropractors, not just with, I would assume PTs, although you guys typically inherit a patient from some other type of evaluation. So, but even in the emergency department, people all the time go to the ED. They're having the onset of stroke symptoms and they get discharged with a diagnosis of mechanical neck pain or headache or migraine or whatever, they proceed then some hours later or maybe a day or two later to go on into full stroke. And so, unfortunately, screening for stroke in progress is not very reliable in actually detecting incidents of stroke. So one of the big problems that we have is, I think, with and we can get into stroke or we can continue talking about assessment.
No, this is fine. We can take detours.
Okay. One of the big problems that we have is that I think it's just stroke is being misdiagnosed. One of the most common symptoms of stroke are neck pain, headache, and those are some of the reasons that you might see a chiropractor, because your neck hurts and you have a headache, right? It's also one of the indications for manipulation. So an indication that a cervical manipulation is going to be successful is neck pain, loss of range of motion, headache. So it's something that's saying, green flags proceed this way for manipulation, but it's also something that's saying, hey, yellow and red flags proceed with caution for stroke.
Sure.
And I think part of what's happening is that there's a misdiagnosis. So there's a study, I sent you some links for studies, but
you did.
One of them is a kind of very large, I believe, an epidemiological study, but it's a study over a lot of people. And he basically looks at stroke incidents after visiting the medical doctor or after visiting a chiropractor. And I believe, funnily enough, it found actually a slightly higher incidence of stroke after visiting the medical doctor than after visiting the chiropractor. And if we just presume that the medical doctor is not performing grade 5 manipulation of the neck, right?
Fair enough.
What we can kind of infer from that is that there's an equal incidence, regardless of provider scene, of stroke following an appointment.
Sure.
And so it's not so much that chiropractors are providing or causing strokes, which is our view in the profession. It's that we are all bad at diagnosing stroke in progress. And so the patient is presenting with symptoms of stroke. You proceed with the usual route of treatment, and following that usual route of treatment, the patient progresses in their stroke. Is what we typically would infer from that particular study.
Sure. And so I guess fortunately, I've, to my knowledge, never experienced a patient who was going through the early stages of a stroke. But I know the big thing we learned in undergrad is the be fast. So is that not particularly reliable in determining that they are having a stroke? Or I guess why don't we have better screening tools, in your opinion?
Yeah, I believe it's just because of the kind of stroke symptoms. They can come on quite suddenly, but they can also be quite gradual. You can also don't have to have all of them. So, someone may not have any facial asymmetries. They may not have any trouble speaking, but they may present with some level of confusion or disorientation or neck pain or headache. Or you can have stroke without neck pain and headache. And so there's a lot of overlap with things, other more benign things that someone could come in with. And also, I don't think anyone would have a trouble spotting someone who's currently having full-blown stroke, right? You've got cerebellar symptoms, you've got all this. Like, the be fast is to help just the general public understand what's happening with someone. Absolutely. A medical provider is probably not going to have any confusion about what's happening if we've got be fast symptoms, type situation going on right in front of you. But it's those precursors, or if you want to even call it the aura, stroke aura. So the symptoms that precede stroke can be more subtle. So it can just be those headaches. It can be neck pain. It can be a slow degradation of vision or of consciousness or understanding. And that's a little bit harder to detect, especially with, your family members might have an easier time selling that something's not right with you than a stranger that you've just met today. It's like, is this person heading into a stroke, or is this just kind of an odd individual? Like, some people just speak in strange patterns. Some people are just
there
odd.
are plenty of those people.
And someone might have Bell's palsy and they might not be having a stroke, right? So, you have a lot of things to consider as a provider. And so I think, but the reason why I say we don't have good screening tools is because from what I've read in the research about stroke, and as chiropractors, we're obsessed with the research about stroke because we don't want to be blamed. Most of the research in the discussion section or the commentary section just talks about how there are not reliable screening tools and how the sensitivity and specificity values for common screening procedures are not sufficient to catch that. Now, some chiropractors, we have chiropractors who people might not like in our profession. We might consider chiropractic defectors. One of them would be Aaron Cabal. He's a chiropractor, does pretty much all rehab, and
I'll get him on my list.
You should. And he does podcasts and stuff. He's a pretty high profile person. Are you aware of Adam Meekins, physical therapist?
Yes, I am aware of Adam Meekins, and I think I have the same thoughts about him as anybody. It's like he has his preferences. I like some of them. I disagree with others, and that's pretty much it.
Yeah. We would kind of consider like Aaron Cabal as our Adam Meekins. So he's kind of like thorn in our side, always, poking fun at us from within and questioning things. But, people like him that are very focused on like that stroke risk or very focused on rehab only would say cervical manipulations carry a non-zero risk of stroke.
Okay,
and
fair enough.
Therefore, due to the severity of the potential complications, it is never worthwhile to do it. So we should never manipulate the cervical spine.
Sure.
And the argument would be that there's research that supports you can get just as good results manipulating the thoracic spine for neck pain and headaches and things like that. And so because of that non-zero risk, you should never manipulate a neck ever. There's no excuse for it, so on and so forth. And so that's one kind of view. And then the other view is like, well, we should be as careful as we can in ruling out yellow and red flags, understanding there's non-zero risk in everything from driving your car to brushing your teeth, right? And so, what level of risk are we comfortable with and the patient's comfortable with, and make sure you do an informed consent. And there you go. So,
sure. Well, and to your point, like, I think my opinion of Adam Meekins in the physical therapy community is if he is getting the outcomes that he wants, as well as the outcomes the patient wants within a reasonable time frame, I am perfectly okay with his style of treatment. And because there's a growing group of physical therapists in the community that do not believe in manipulative care, whether graded mobilization, soft tissue, or manipulation. And what they're saying is that it's not skilled, it's not specific, it's not this, it's not that. You can get just as good examples, just as good outcomes with other interventions. And my response to that is, you've never worked with someone who is a truly great manipulator. And because in my head, like, how do you know you're good at something? You get the result you want from the intervention you provide. And so the people that are like, I just never got outcomes from my manipulative interventions, it's like, well, that's probably your problem.
Yeah. So are you open to the fact that maybe you weren't good at it? And then I'll even double down on that, because when you're not good at something and you're not getting results, then you have a tendency to lean away from the things that aren't working and lean towards the things that are. So let's say that you're great at graded exposure and, building up a program of loading for someone, and then you're not a good manipulator. Well, you're going to progressively move away from manipulations, which means that every time you go back to manipulations, you're less and less kind of sharp with it because you're rusty because you don't use it. Yeah. So it's an intervention that you weren't good at to begin with, that you use very little, you don't believe in, right? So if I went out and tried to do a rehab program with someone and I have barely any rehab education, I don't really believe in the value of the rehab that I'm doing anyways, and maybe I'm not good at my exercise selection, what are the odds that I'm going to have great results with them? Right? Terrible. It's not very high. And so your heart's not in it. Your practice isn't there. I think that's right. And I think, there are studies that show that experience level of the provider doesn't seem to make any difference when it comes to palpation, for example, and things like that. But I think it's something that's very difficult to study.
Sure, absolutely.
And I also had a problem because the main study they cite when they talk about that, for example, experience level, actually the less experienced therapists had better results than the more experienced therapists. But they used years in practice as the metric that determined experience or skill.
Sure.
But you could do something for 25 years and still be bad at it. And we have politicians, and you could work at the DMV and be the slowest person in the driver's license division, but you worked there for 25 years. So doing something for a long time doesn't necessarily mean that you're any good at it. It just means that you didn't quit. And so you can't really use years of experience as a metric for skill. And the problem with manual therapy is it's incredibly difficult to even conceive of what would be an appropriate metric for skill other than the subjective experience of the people being treated. Right. And that was my whole thing, is I know that manipulation is a skilled procedure because I have had horrendous manipulations that felt god awful, and I
Mhm.
needed someone to fix me after. And then I've had incredibly, almost miraculous manipulations where it was smooth, it was comfortable, I felt better immediately.
Mhm.
Um, and they weren't even from people that, like, I've had some of the best adjustments of my life from people who I'm not very fond of personally.
Sure.
And so, you're almost frustrated that they're so good because you don't like them. And so it's like, it's not like I was expecting you to be amazing. I was actually wanting to not like your treatment so that I could confirm that you're a dickhead. So, but those experiences, to me, there is something experiential about an incredible manipulation that I think is, I don't even know how you would begin to quantify that in a research project. So when you're working with people, there's only so much hard data isolation that
Mhm.
you can do. And that just creates a problem in all kinds of aspects.
Sure. Well, and that's why I see a lot of the cervical manipulations that you do and you post on Instagram. And I know that I could show them to some of the people that I know, and they'd be like, "What the heck? He's going to blow over vertebral artery." And again, in the community that we currently live in, it's so black and white. And to your point, like, you have practiced these. It's like you do pre-screenings. Like you've already said, if you have concerns, you put them in that position and leave them there. You put them in the manipulative position and you leave them there. It's like you are doing, like, ultimately it comes down to a few things. Are you screening appropriately? It's like, are you experienced with the technique that you're doing? And like you said, it's like if you are in the right position, the amount of manipulation, and it's the same with PT, because we don't necessarily have the same manipulations, but we do have cervical manipulations. And I have buddies that they're like, doot, 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 and they get there every time. Cervical spine has never been something that is my jam. I am a lower quarter type person. It doesn't mean that I can't confidently treat upper extremity, but if you're looking to get your C spine manipped by me, like, it's probably not going to happen. I just don't find it in the cervical spine the way I do in the lumbar spine and the lower body. And so a lot
I
of,
would
like,
love to spend like an hour with you, and we'll have you walking out of there adjusting cervical spines like a pro.
well, and I believe you. But to that point, like, if you're in the right place, the amount of force that the joint really needs to experience to be manipulated is not high. And so, of course, everyone has been, like you said, they've been to a bad chiro, and they get them into a semi-awkward position. And those patients that are like, I wasn't comfortable, and then they just wha-bam, and they just ripped them. And they're like, I did not like it, wasn't good. But again, it's like you can't make that assumption. It's a N of one. Like that person, it was not the best. And if they went to, like you said, there are chiropractors and even PTs. Like, my boss has done different things to my shoulders, my clavicle, different places. And it's like, immediately I'm like, wow, like, that is incredible.
And one
And
of the biggest benefits, I think, about manipulations is that immediate before and after. You show someone, like, if someone's in a ton of pain, even if you don't take them from 8 or 9 out of 10 pain to 0,
sure.
you just take them from an 8 to a 4 in just a few seconds.
Mm-hmm.
You show them that their pain is changeable, and
Mm-hmm.
they can imagine a pain-free future on the horizon. Their whole outlook on treatment changes. Sorry to interrupt you, but that's one of my favorite things about it from I don't know what you would call that, a pain science or a biopsychosocial standpoint, right? It's just that immediate proof that things can get better for you.
Right. And that's why I am a big believer in manipulative therapy. Like, you listen to these people that are more exercise based, and then we'll get off our tangent. We'll go back through the eval process just so I don't take too much of your evening. Like, it's like, well, how long time better? They're like, oh, you're back, probably won't feel better for like 6 months. Like, we're going to need to go through all these exercises and get you deadlifting and get your back strong and blah, 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 blah. And it's like, okay, well, why can't I just manipulate the pelvis? Why can't I manipulate the hip? Why can't I manipulate the shoulder or the T-spine? It's like, if they're having these issues, and if it gets them feeling better and changes their mindset, their willingness to exercise or move, it's like, why wouldn't we do that?
Especially when I
agree.
It is probably one of our most time leveraged interventions that we have. I mean, it is something that is once you're good at it, it's remarkably easy to deliver for the patient. It's remarkably easy for the patient to consume. It's very unimposing. It's quite low cost. I don't know. I could sing the benefits of manipulation all day. I'm obviously a biased, point of view, but I just can't see why you would want to exclude manipulative therapy from your approach. But to go back to something that you said earlier, like about like the force, this is something that's very important. And I've recently kind of stumbled upon an analogy that I think works perfectly. Because if you watch me adjust someone's neck, it's quite a large movement. So it almost looks high velocity, high amplitude. But there's kind of an input into the joint, and then there's this kind of non-input follow through, like a follow through to the movement. And so the entire distance traveled by my body is not force into the joint. The force into the joint is still low amplitude, but then there's this kind of follow through that's part of the movement and the process for me. And it can look like it's an incredibly high amount of force, but the best way I've found to describe this is like the sweet spot when you hit a baseball. Or like if you've ever hit a baseball kind of not properly, and you feel the reverberations down the bat, it can almost hurt your hand if you hit with like a wooden bat, right? But if you hit that baseball just right on the sweet spot, it's like butter. It's like you didn't even hit the ball at all. It just goes, and that ball goes flying.
Right.
That's kind of what happens when you are adjusting with the joint lined up properly versus improperly. And it really translates into the comfort in the way that force, if you don't have the joint lined up properly, so force can go in one side, out the other side, and it follows the natural mechanics of that joint. And if you get that wrong, you get this reverberation of forces. So you put the thrust in, the joint surfaces impact one another, or whatever happens, things aren't lined up properly. And that force reverberates through all the tissues, through the joint capsule and the musculature, and you get this kind of straining effect, especially in the neck. It's very uncomfortable. If you get that joint lined up just right and your directionality of your impulse is just right, you hit it like a sweet spot in a baseball. That force goes in one side, out the other side. It just dissipates instead of reverberating through the body. And you experience an incredibly comfortable, smooth manipulation. And that's what you want to look for. And the levels of skill come in providing a manipulation that is comfortable like that and effective every time. And the better that you can get at that, because everybody's going to be a little bit different. Some people have larger necks, smaller necks, more robust soft tissues, weaker, more flaccid soft tissues. So the vectoring, the directionality of your thrust and the position you have to get the patient in so that they're perfectly relaxed. That's the other thing. You put people in these pre-manipulative positions where they're fighting against you because the position is so uncomfortable or unnatural. And then you try and muscle through that with thrust. Yeah, you're going to strain all the muscles in the neck. So you need the patient to be relaxed. You accomplish that through positioning, but that positioning also needs to be appropriate so that the joint is lined up properly and you can deliver your thrust properly. And so it's a lot of moving parts, especially in the cervical spine. There are certainly extremity joints that are much easier to manipulate in a smooth way. Everyone can probably pop their finger in a way that is non-painful, right?
Oh, no, thanks.
But probably not everyone can pop their neck in a way that's non-painful or pop someone else's neck in a way that's non-painful. But when you get great at that, you really start to see incredible results because you're getting that afferent barrage, you're getting all these wonderful effects, and you're minimizing the negative side effects of a manipulation like soreness and pain and things like that.
Sure. Well, and I think for anyone listening, no matter what intervention you choose, there will be primary outcomes and there will be secondary and sometimes unintended outcomes. And you've got to weigh those. Like someone who performs a poor manipulation, whether it's a chiropractic manipulation or a manipulation or mobilization performed by a PT, like if it's bad, you're probably going to get more secondary consequences than you would like. That could be guarding, it could be swelling, it could be soreness, it could be any number of things. And that's why I guess I can't emphasize this enough for anyone listening. If you're wondering if you're good at manipulation, or if you're wondering if the person teaching you is good at manipulation, then you've already answered the question.
Well, certainly if they demonstrate on you, right, you should immediately know. The appropriate response from getting a manipulation is not to hop up, grab your neck, and kind of rub it like you're sore, right? The appropriate response is just an immediate, sigh of relief. at having experienced it. So certainly if you personally get an adjustment or a manipulation from someone, you should immediately know their skill level. It's when I get adjusted by another chiro, I immediately know where I can rank them on the scale.
Yeah, absolutely. So jumping back, long detour. I enjoyed it. I hope everyone else did too. That was fun. So you've kind of ruled out these kind of insidious things. Strokes, as much as everyone else, and I would say particularly PTs and physicians, as much as they would say, how did they not know they were having a stroke? It's like, well, do you know that you would catch it? It's like, or would you come in?
But if you look at the statistics, like everyone can look this up. You can look at research, you can look at the statistics for missed or misdiagnosed strokes in the emergency department. Arguably the place in the world that should be most equipped to diagnose strokes. It is tremendous. There's a very high incidence of missed stroke, even in the ED. And then now you go into just some random providers, general population practice who maybe stroke isn't front of mind. Maybe they don't have as advanced of screening tools. And it's easy to see how someone could miss a stroke in progress.
Sure, absolutely. So I would like to know a little bit about, because you said, can I manipulate them everywhere, or are there certain joints that are kind of excluded from a stability stance? So I know in physical therapy, let's say the way my mentor describes it is there's numerous end feels to a joint if you're doing a manual assessment of how it feels. Like there's empty, like they experience pain before there's any resistance of any kind. And you lift their arm and they're like, ow. And you're like, well, your arm goes up here. Why are you saying ow halfway through? And then there's a number of others, but from my purposes, I'll describe three. There's empty. I will call it bogged down, where it's like the joint will go, but it's like molasses. It just kind of, it doesn't inherently just loosen up to that position. And then there's a hard or firm end feel where it's like, this thing is stuck. So from the PT perspective, I have been told and I have learned that if it's bogged down, you do graded mobilization. And if it's blocked, you can mobilize, but ideally you would manipulate. And if it's empty, you're maybe looking more at soft tissue interventions. I'd love to know kind of how you're assessing the kind of end feel and how you're deciding where you can and can't manipulate. I'd love to hear that.
Yeah, so we would probably treat, we definitely agree on that hard end feel, right? So you encounter what would be like a hard block in end range, in range of motion, but you encounter it before you reasonably should be reaching end range of motion. So let's say cervical spine, you're at 45 degrees of rotation, and then it locks up. Well, you should have 80 degrees, maybe 90 for some people. And so clearly it's a deviation from normal range of motion, and it's an aberrant kind of joint movement pattern. Sure. So then, as long as there's not, so you've ruled out something like DISH, diffuse idiopathic hyperskeletal or whatever the term is, where you have this diffuse bone production throughout the cervical spine, or osteophytes, or things like that. Anything that would explain the abnormal range of motion or the abnormal end feel. So in the absence of those, that's a prime target for manipulation. And then I personally would think that those boggy joints, they tend to be a good indication for high grade manipulation as well.
Oh, okay.
Typically, that boggy feeling isn't. It's an indication of like inflammation or of swelling. I'm forgetting the technical term for swelling at the moment. So
that's okay.
Effusion. Anyways, now what we would say as chiropractors is that the actual irritation of the joint capsule from the dysfunction that's happening at that joint is creating local inflammation. That local inflammation is giving it this kind of spongy, boggy feeling.
Right, almost as if why am I not remembering terms now? Almost like the synovial fluid has thickened from inflammation.
Yes.
Okay.
And so we would view that as an indication for manipulation, because what's driving the inflammation? The irritation that's being caused by the aberrant pattern of motion. The way I describe this to patients is, have you ever done a group project in school? Yes. Sometimes there's someone who does all the work, and then there's people who don't do their fair share of the work. People who are doing their fair share of the work or having to do extra to make up for the people not doing their fair share, they get irritated with that person. And that's kind of how we view the spine. So you have sections that are functioning normally, sections that are not moving as much as they should. You are asking other regions of the spine to take up an abnormal extra amount of stress or work or range of motion. They get irritated as a result of that extra motion. You may get inflammation, and that causes that feeling. So it may not necessarily mean that you're on the right specific joint, but it is an indication that you're in the correct area. So you might target manipulation at that boggy joint. You might find a more hard infield joint that is near the boggy joint that might be a more appropriate target. But generally, that inflammation is coming from something because it's local inflammation, not systemic.
Sure.
Local inflammation is a sign that there's a local dysfunction happening. And so whether that's physiologic or biomechanical, whatever, we can all argue till we're blue in the face about the causes and stuff like that. But to me, that is also a good sign for manipulation. Empty infield, it's interesting because I've never heard empty infield as having a pain component. So empty infield is kind of what you would feel for us. I've always heard it described as like that joint where you're looking for end range and you never find it. Like it just, it's just open, very hypermobile, very loose, potentially dislocated. I've felt a few dislocated joints where you have that feeling like you push and there should be an end there and it's just not
but there isn't.
Yeah.
Sure. And that could just be that a lot of the patients that I have with empty infields are normally into some type of flexion. And so it's not like their arms like, woo, like going over. It's like, ow, normal range, or like knee flexion, normal range, but ligamentous tests are normal.
Yeah.
So I would say you are correct. I just often find it personally that there's some type of pain because that's why people come to PT.
But there's probably reactive guarding, right? So if you've got like a chronically dislocating shoulder, you're not going to let someone place you through full range and risk dislocation. You're going to have a pain, or even if you don't have pain, you're going to stop the motion before they get there. Anytime we feel something like that, where there should be a normal end range that's not present, maybe there is a slight like clunking or shifting of the joint that should not be there. Like this is very often overhead movements. You get this inferior kind of shift of the humeral head during abduction that's inappropriate for normal shoulder movement.
Sure.
Those are all signs that a high-grade manip is probably not appropriate in that region.
Okay.
So if you're hunting for that stuck segment that you're expecting to be there, and as you go hunting, there is no stuck segment, it's a good sign that we are not on the right track for being in the appropriate location or not being appropriate to provide high-grade manipulation, at least at that level. It doesn't mean there's not an adjacent level that would be more appropriate, but certainly there. It's not appropriate because you don't want to put force into this if you don't know where it's going to be going through.
Sure. So with from the PT perspective, like if it's something's bogged down, like it's bogged, the theory that I have been told behind it is if it's bogged down and you begin to mobilize it through like its available range, you essentially are almost like not accordion. It's, what would you say? Essentially, you are creating fluid movement that will help the body clear out the inflammation that after, that's my dog ringing the doorbell. The idea is if we create a smaller oscillation, we can improve fluid flow and maybe clear out that inflammation. I would like to know more about what is the rationale for the manipulation. Not that I'm against it. I'm curious. Do you guys think that going against it will help it clear the inflammation faster? What is the
generally, and this may just be my opinion, but I think generally the chiropractic thought process is you want to fully address the joint, any binding that's occurring or any aberrant movement.
Okay.
And so if there is a risk in a lower grade mobilization of not completely what we would call, most chiropractors call clearing. So you've got cleared the joint. There's more of a likelihood when you're doing a lower grade mobilization that you may not create full clearing of the joint.
Right. You may have left some in the tank when you could have taken it out. Okay.
And so the viewpoint is if I have the ability to achieve 100% clearing, why would I willingly decide to use 50% clearing or 75% clearing? That's kind of the approach there. In just that if we fully separate those joint surfaces from one another, we elicit an audible release. We create the motion that was not there or was altered or strange there. that should then allow the homeostatic mechanisms of the body to regulate in that area. So there is still kind of this emphasis, even if you're not using innate intelligence, there is still kind of this emphasis in chiropractic on if you clear the spine, the body will sort the rest out. And it's like, well, why does adjusting help this and this and this and this and this and all these conditions when you're just adjusting the spine? It's like, because the body wants these things to be better. It's just having a hard time doing it. When you clear the spine, the body will sort it out. And so I sometimes joke that chiropractic is one of the most complicated, most simple things that there is, because it's like, just, is it screwed up? Is it safe? Crack it and see how they come back. And that's literally what I do. I mean, almost all of my treatment plans I would consider a trial of care. Like, we're going to try these manipulations. We'll see if we're in the right ballpark. If you're responding appropriately, we'll continue until you get better. If you're not responding appropriately, then we'll discontinue and we'll talk about, okay, do we need to alter the treatment plan, or are you not in the correct office? Should you be seeing a PT? Should you be seeing a massage therapist or a medical doctor?
Sure. So I guess on the PT side, the way that I would address the kind of, am I clearing the whole joint? Like, oftentimes, that's where it comes into like graded mobs over a dosage of time, because essentially you get a low amplitude but a high velocity. Like you said, less than that 200 milliseconds, you are delivering what you want to that joint. And the kind of rationale from a PT's perspective is, if we take that joint and it's like, and we mobilize it, but we mobilize it for a longer period of time, we can kind of milk to that same degree what we would like to from our perspective. And I don't think either one's right or wrong, because I think it comes down to what you said. It's skill level with what you're providing to the body.
Is it usually looked at through, for example, like force escalations? So we've decided for this joint, grade 5 is not appropriate, so now we're going on a force de-escalation. Or even if, let's say any approach would be appropriate. So like, any grade all the way up to full grade 5 manip would be appropriate. Would you still feel there are cases where, even though grade 5 might be appropriate, you would still select a lower grade because you think it would be more therapeutically? I guess what I'm saying, is there use cases where mobilizations are more effective than manipulations? Or how would PT address that question?
Sure. So from the perspective of me, with kind of my own bias and my learning from my mentor, like, it really comes down to the end feel. Like, if it's bogged down, I will choose probably a 3 or a 4 graded mobilization. If it is highly painful, I would do a 1 or a 2, unless 1 or a 2 elicited enough of a neurological change I could push into 3 and 4, and maybe a 5 depending on end feel. If it's a firm end feel, I think, in my opinion, if it's a firm end feel or a hard end feel that should be manipulated, and you are unwilling to, it is likely a competence issue. Like, I've had experiences where it's like, that is locked up and I should really manipulate this, but realistically, like, I don't feel my expertise at that time was sufficient where I was willing to or able to provide the manipulation. So in my opinion, it's all, if the end feel is not firm, I would not manipulate it. Like, from my training, I would mobilize. And if there's someone who would be willing to manipulate it, they would simply have to adopt another framework for decision-making for their manual interventions.
Got it. Yeah, and I think there's some chiropractors may disagree with me on this, but generally when we're thinking about switching from manipulation to mobilization, it is usually through some type of safety or risk assessment, or some type of, like, it's too painful. So we typically don't pull back away from full grade 5 unless there's some type of contraindication or concern that we have. We're going to go ahead and grade 5 it. And, it's like inflammation can be one of them, or you can also get that boggy end feel just from muscular activity. So like muscle spasm in the area. Sure. And we would view the inflammation, we would view that muscle spasm, we would view all those things as indications of what we would call segmental dysfunction, or some chiropractors might call the subluxation. So when we feel stuff, whether it's boggy or hard or whatever, we're going, yes, we found the correct location, right? This is aberrant. And so we're typically going to jump straight to grade 5.
Sure. Well, and so that would fall like to your question, like the muscle guarding could be limiting the joint mobility. It could be other things. There are other end feels that we use. There's firm ligamentous end feel, firm muscular end feel. There are these kind of differentiated end feels that I guess I oversimplified into the bogginess. So yeah, no, I think though I understand where you're coming from. And I hope for anyone listening who may be screaming at their radio right now, I hope I did some justice to the PT explanation.
I feel the same way about my representation of the chiropractic profession. I feel like when we put this out, I might have some unhappy people in my own camp. Like, why the hell did you say that?
Yeah. And my opinion to those screaming at your radio, shoot me a DM. You come on. Yeah. Why don't, if you are so convinced that you can give a better explanation, to potentially thousands of people, hundreds of people that will listen to this, be my guest. Come on. We'd all love to hear it and benefit from how you describe things. So I guess what was I going to ask? I was excited to ask about this. So you had brought up, you clear the insidious things. We had brought that up. You had talked about the real things we're looking for, like weight gain, weight loss. Is there hypertension under control? Is it exacerbated by different positions? Same with cholesterol and diabetes. Screening isn't great for stroke, which I think is something that we should go again and again. If there's anyone screaming, it is clear for stroke. Come on. Everyone would love to hear you describe how clear it is. And then we went to, how would you know you're doing a physical assessment? You're feeling the joints, you're feeling for end feels. And essentially if you're having an end feel where you shouldn't, maybe it's coming on early, that is maybe a good candidate to manipulate, including if it's boggy or firm. If it's empty and you're not getting an end feel where you should, that would probably potentially describe some type of instability or something that you shouldn't be yanking or pushing on. And you had brought up a third thing. You said, should they be here? Can I manipulate them everywhere or not? And
for example, is only one region appropriate or not?
Yes. Yep. That was going to be my question. So are you always manipulating, and we'll kind of finish on this. Like you've given us a good chunk of your evening and I am appreciative. Are you always manipulating both sides? Because I think that's something that is commonly experienced in chiropractic, where they go and it's like, I do one side, I do the other side. There may not be as much of a system where it's like, I only need to do this section on this side and that section on this side to put this system back into balance.
Yes. So this is where each individual chiropractor will probably have different responses, and they're probably going to be pretty passionate about the responses, because this goes into your fundamental level, your fundamental assessment and your fundamental philosophy for treating. So I generally keep things very, very simple.
Okay.
Is it stuck? Is it not moving properly? Can I provide a manipulation that will normalize movement? Then my answer is yes. So I don't care if I adjust 5 segments, 2 segments, 28 segments. I will adjust every joint that can make noise in your body if all of them feel stuck and abnormal in their movement. Now, you may make an argument, if all of them feel that way, is it really abnormal or is that their normal?
Sure.
Just bear with me here. Right?
Sure. Yeah, it's for the example.
Yeah, so I would be happy adjusting every joint in the body if that's what the patient needs. Now, some chiropractors believe that from looking at x-rays, you can kind of find what we would consider a primary subluxation, and then you have secondary or compensatory subluxations.
Okay.
There are different indications. I don't do this, so I'm not sure exactly what they would use for indicators. Maybe it's degree of displacement from normal, whatever. But they would analyze either the x-ray or they would analyze your body, and they would do their best to identify the primary subluxations. There might be 1, 2, potentially 3, typically not any more than 3.
Okay.
And they'll adjust only those.
Okay.
And the goal is to restore alignment or to restore balance. So they might adjust only the atlas, only on the left-hand side, and then adjust only T3, only on the right-hand side, adjust only L5, only straight P to A into extension.
Okay.
And they would say, we have delivered with these 3 single manipulations. We have delivered balance in the body. And now we're going to see from this visit to your next visit, how does your body react and adapt, or how well do you, in chiropractic, the term would be holding. Okay. How well do you hold your adjustment or hold your alignment?
Okay. And
So
they
that is a
primarily
very,
decide that from the x-ray.
yes, or through symptomatology. So for
Okay.
example, they'll kind of train patients over time, it seems like. They may not like that I've said that, but they'll kind of train patients over time where when you feel the headaches come back in. And so the patient kind of equates that my atlas is out because I'm having a headache. They go
Oh,
get adjusted,
people
put the
hear that
atlas
all the
back.
time. They're like, I'm out.
Yeah,
I got to go back.
I'm
I'm
out. You
out.
got to
I
come
got to go
crack
out.
me. And so the
Okay.
patient equates that. And so then you would be say, oh, yep, you're having a headache. You are out. Let's get you aligned. Right. And then they would go do whatever adjustments are necessary. Now, typically, you're going to do that. The docs that I just described, that process, very few segments and not bilaterally, they're going to fall usually into that X-ray analysis alignment camp. So
Okay.
they will take an X-ray, treat for however long. Sometimes they don't even really care about the patient's symptoms, whether they're changing, not changing, getting better, getting worse. They'll say, I don't care how you feel, I care how you heal. And then they're looking, 3 months down the line, take another X-ray. Is your alignment better or not? Even if your pain is worse, but your alignment is better, a lot of times they're going to say, we were successful. Right now, I'm being a little bit hyperbolic there,
Sure.
but some
Absolutely.
docs are like that. We don't care how you feel, we care how you heal. But most docs are going to care about how the patient feels, and they're going to do their best to bring the patient relief. I personally, my philosophy is if it's stuck, I'm going to adjust it. I have no qualms about adjusting both sides.
Sure.
I have no qualms about adjusting both sides of the same segment at all. So, people get that. I get that a lot from my profession. They'll see my videos. They go, it looks like you did the occiput on both sides. Why did you adjust both sides? I say, both sides are stuck.
Sure.
I just that's it. No further explanation needed. It's not rocket science. Was it stuck? And what I always say is, to me, is it better that your patient comes in and I adjust only 3 of the most stuck segments? I leave everything else that's stuck alone, but I was very specific. Or is it better for your patient to walk out with as few stuck and dysfunctional segments as possible? I think if I can, I would like my patient to leave with as few stuck and dysfunctional segments as possible. And the benefit to that is I don't have to be super precise in determining primary and secondary subluxation. I can just adjust everything that I feel is sucks, and I'm going to hit all of it. Now, their argument would be if you're adjusting inappropriately or excessively, especially putting an emphasis on secondary subluxations, not primaries, you'll actually drive them further out of alignment and hinder the healing process. What I can tell you is that clinically, that is not what I see in the results I get for patients. What I see is that when patients will oftentimes spend 3 visits a week initially in another chiropractor's office, I can treat that same type of case in 1 visit a week in my office because I do more robust adjustments and I adjust more segments than most chiropractors do. I want to see my patients less because the treatment is more dramatic. It is less subtle of a treatment. So I want them to, after I adjust them, I want them to leave my office and go back to their daily life and let that settle for a couple of days before I have them come back and we reevaluate where they're at. And I just try and take a clean slate to every visit.
Right. And in my mind, that seems logical. Like if you're saying, I'm going to treat everything that's dysfunctional that I can in a way that is ethical and I'm competent in doing, why wouldn't you? And anyone who's listening, they're going to be like, well, obviously it's like the more visits you have, the more money you pay. Is an option. Not saying that everyone who does that. Maybe people just have a different treatment philosophy. But okay, so in your mind, you're like, if it's stuck, I fix it. If it's stuck on both sides, I'll fix both sides. But you're not someone that's like, oh, it's stuck on the right, but the left felt fine. I'm just going to hit them anyways.
No, but that would be what I would consider an inappropriate use of manipulation. So chiropractic seems really simple and easy because it is, right? Fundamentally, all you have to do is put someone in an appropriate position and thrust and make their spine crack, right? Where it gets complicated is all the assessment and things that go into that. So I'm not going to ever just lay someone down on the table, not feel for restriction, and just rip an adjustment willy-nilly. I'm also not, even though I don't personally believe you can be segmentally specific. So I think it's silly to think that when I adjust what I would call to you verbally C3 on the right, that I'm only affecting C3's right facet.
Sure.
The superior facet or inferior facet, whatever, right? I think that's kind of unrealistic. We have this kind of cascading effect. Sometimes those cavitations come from the other side of the spine, whatever. As long as you've matched your restriction or your dysfunction, the thing that you've diagnosed, with an intervention, and you see an improvement in the original assessment after your treatment, you can reasonably decide that your treatment has been effective. And then you're looking at that trend over time to see if not only is an individual treatment effective, but is the plan overall effective. And so I would never suggest someone walk up to someone on a table blind and just let manipulations rip without assessing. But I also don't think that you need x-rays and some very complicated assessment method. I think people have a tendency to overthink this. It's like, is it sensitive? Does it have aberrant range of motion? Then hit it and see what happens, right? A lot of what I do with patients is we're going to hit it and see what happens. Like, you come back next visit, you're like, doc, I think I feel a little bit worse. Like, okay, maybe we used the wrong approach last time. Let's select maybe more gentle techniques or different positioning. Some people respond favorably to supine versus prone manipulations. Some people respond favorably to different things. So I love that your dog is ringing the doorbell, by the way. But
no, she's brilliant. Yeah, she will ring the doorbell anytime she wants to go outside or she's sick or she needs to go to the bathroom. She's brilliant. Right. And I think realistically, we line up identically with that. It's like, if there's reason for me to treat it, I assess, I treat, I reassess. If what I wanted to get out of the intervention is what I ended up getting, it was a success, and we're going to see how long that intervention holds. Because to your point, like, if you're putting the body back into, like, if the body has a margin of error that its system likes to operate in, and your manipulations are putting them back in there, they're not going to have an issue. Oh, Days. Oh. She walked around and unplugged everything that's behind me. So if you are putting the body back into Daisy, chill. If you're putting the body back into a system where it thrives, like, it shouldn't need more intervention to keep it there because it's happy.
Correct.
And that's what
at that point, more intervention might not be appropriate. So most chiropractors are going to start with more treatment and then taper the treatment plan down. So, it might start for many docs, might start 2 or 3 times a week, then tapers down to once a week, then down to every other week, every 3 weeks, once a month. A lot of us like to put patients on once monthly or once every, month and a half for wellness care. For me, I tend to start people at about once a week and then taper down. I'll do once a week for 4, sometimes 8 weeks, depending on how they're responding. Mm-hmm. And I'm looking for them to go from 1 week to the next with no symptoms before they go down to the next frequency. So they go 1 week to the next, They come in, hey, doc, I'm feeling great. Awesome. I'll see you in 2 weeks. Hey, doc, I'm still feeling great. Awesome. I'll see you in 3 weeks, and so on and so forth. And that tapering is because you can over-treat people. You can take someone who comes in, hey, doc, I'm feeling great, and adjust them into having symptoms again. And you can do that quite easily by delivering manipulations that are not appropriate. So we see this oftentimes with seminars and educational things because people don't have the dysfunctions that we need to train the manipulation on, and we decide to do them anyways. Like, when I teach people to adjust, the jaw, most of the people in the room don't have active jaw pain or any of the indications for a jaw manipulation. And yet we're still going to manipulate their jaw because everyone needs to practice the technique so that they're capable and they can develop the skills. And that's where you see all kinds of issues. You see all kinds of issues from these trainings because we're delivering inappropriate care for the purpose of developing skill. And that's why we do these trainings on each other and not on the general public, because it would be unethical to do that to the public, but we can beat ourselves up, no problem, right? So,
sure. So I guess I'll end with potentially a hot take for you. I have heard it said that chiropractic, through manipulating the spine, through this innate intelligence.
Correct.
Okay, great. I'm glad I remembered that. They talk about the impact of chiropractic on gut health, on hormone secretion, on diabetes, on any number of issues. I guess if you'd like, I'd like to know kind of what your thoughts are as, could there be something to that? Do you agree with it? Do you not agree with it? And then if you'd like, at the end of this, if you'd like to put in a little plug for how people could interact with you or follow you or anything like that, we can wrap up.
Yeah. So we have some pretty famous charts in chiropractic history. It's called the Merrick chart. And basically it outlines the sympathetic or the autonomic nervous system, sympathetic, parasympathetic, what nerves go where and from what region in the spine they originate from. And so that chart has been used as a justification for basically chiropractic treating anything from glandular issues to asthma to autism and ADHD. I think that characterization is a little bit inappropriate, but I won't say that none of those things can be affected. Right.
Sure.
Historically, the chiropractic thought, like from the old school philosophy, was innate intelligence should flow from the brain and spinal cord out to every end organ and tissue cell to maintain those tissues in their proper form of existence. Subluxation in the spine reduces the flow of innate intelligence, which will result in end organ disease. So chiropractic historically was not a musculoskeletal profession. It wasn't. It was based on treating the whole body, organ systems, everything all together. And so the belief was that subluxation, used to call it, there were even signs, they're really funny posters, said subluxation, the silent killer, right? Get checked today. But the idea was that if your subluxations persist in, the region of the thoracic spine that's responsible for, your liver function or whatever, you will eventually develop liver disease that can then go on and progress to death. That was the understanding. So chiropractors literally thought, and some of our more philosophically based brothers and sisters still think, they're literally saving lives by preventing organ disease deaths through chiropractic.
Through manipulation.
Now, right. What I will say is that the stress response and cortisol levels and all of those things that happen in the body can impair healing, right? The more stressed out somebody is, the worse that they're feeling, the less they're going to be able to heal, rest, digest, relax, right? And so to a certain extent, could musculoskeletal dysfunction be putting someone in a position where they have slightly impaired or suboptimal organ function? Yes, I believe that could be the case, right? So I've had people tell me that their digestion improved after starting to get adjusted. I kind of say, oh, what a happy accident. Right, that's my whole take on this. Well, I heard chiropractic can help with your asthma. I'd say, I'm not going to treat you for asthma. If you don't have any condition other than asthma that would warrant being treated, then I'm not going to treat you at all. But if we happen to treat you for your neck pain or your mid-back pain or whatever, and your asthma improves, we'll just call that a happy accident. And I'm thrilled to hear about all of those things. There's lots of stories of people who were infertile suddenly becoming pregnant after chiropractic care, and the list goes on, which is kind of the anecdotes that fuel these approaches. So I will say I've seen all kinds of things that don't make sense. I've had people have improvements in hearing, improvements in their vision. I had a guy who had to go have his glasses prescription changed to a less strong corrective lens after getting neck adjustments from me for about a month.
Yep, good clarification.
All kinds of weird stuff that has happened. That has never been the goal or stated goal of treatment. And it also won't, we still have to satisfy medical necessity. An adjustment is still considered a medical treatment. So we have these things that go into the diagnosis and into the assessment that need to be met for the intervention to even be considered appropriate. And that all still plays a role no matter what organic disease is going on. But some chiropractors are going to claim they cure cancer. I think that's unfortunate, but that is the case. Most of us, though, kind of fully embrace neuromusculoskeletal care. And most of us are kind of like, maybe it helps organ systems, maybe not. It probably just helps you in general. And I would say that is probably a widely adopted kind of stance by chiropractic in general.
Sure. No, and I think that's a good way to treat it. You're like, you're coming here. I am a specialist in manipulating, especially the spine. If there are limitations in the spine, that's what I'm aimed at. But from your perspective, you're like, don't come to me because you have diabetes. Come to me because you have something back related or some type of pain, headache, neck pain. You said particularly you're kind of upper quarter specialist. So like T-spine pain, neck pain, headaches, all that jazz. It's like, come see me for that. And if through manipulation you experience other improvements in your health and wellness, like great. But don't come to me because, oh, well, you manipulated Jerry and his eyes got better. It's like, I want you to manipulate my neck. So I think that's a very logical.
Exactly.
Yeah, I think that's a very logical way to go about it. And I think for anyone listening, they will appreciate kind of the explanation of why, like you said, those philosophical or kind of those kind of people that are more on, maybe potentially on the outskirts, why they do that. So, Strat, this has been awesome. Thank you for your time. I know that people can find you on Instagram. I believe is it just Dr. Strat Poulson?
So on Instagram, it's going to be at Strat Poulson, Strat Poulson, Poulson.
Okay.
That is probably the best way to get a hold of me. I mean, on TikTok, I'm at Dr. Stratton Poulson, YouTube, Dr. Stratton Poulson, if you want to just see videos. But if you want to get a hold of me, the best way is Instagram. I actually don't have like a social media manager or anything. So if you DM me, you're going to get me and I will respond to you. That's how you got me for this podcast. You're just like, hey, do you want to come on? And I was like, yeah, let's do it. So that's the best way. And if you're interested in any of my online manipulation courses, those are all in the link in my bio on Instagram. So you can go over to the website. I do cervical spine, thoracic spine, lumbopelvic, and full extremities, including TMJ jaw manipulations, manual grade 5. So if you want to see some wild manipulations and learn them, you can do that. You can also come to my in-person courses. So I just taught in Sweden, a big group of about 35, 40 physiotherapists over there. Frequently teach physical therapists as well as chiropractors and osteopaths at my in-person seminars and my online courses. So I have no profession prejudice. I think that as long as you want to help people with manipulations, I'm more than happy to help you get better at them. So that's my stance on it. And Instagram is the best way to find me, at Strat Poulson.
Okay. Excellent. And for anyone listening, I will include his website and all that jazz in the show notes, if that makes it easier for anyone on whatever platform you listen to this on. Well, Stratton, thank you so much for your time. And for everyone, thanks for listening. We know these conversations are never short because we'd like to get into the bits of nuance that it requires to actually get this profession moving forward, how people understand it, how we practice it, and how we help others with it. So again, thanks for coming, Strat. Thanks everybody for listening. And as always, happy to have you here.
I'm happy to be here. Thank you.
Thanks again for listening, guys. Again, happy to have you. If there is anyone who would be interested in coming onto the podcast, please reach out to me at Perfecting PT on Instagram. You can see that at the bottom of the screen. You can also email me at perfectingpt@gmail.com. If you would be interested or you know of anyone who would be interested in coming on the podcast to just talk about the systems you use, your specialty, and how other people could benefit from that. Also, if you have not already, I'd really appreciate a subscribe to the podcast as well as a rating. The better the rating, the more likely people are to find the podcast that would also benefit from it, and we can continue to have great conversations. So, everyone, thanks.